Welcome to part 1 of our lung cancer review for USMLE Step 2. In this video, we will master the classification of lung cancer subtypes including adenocarcinoma, squamous cell carcinoma, large cell carcinoma, small cell lung cancer, and carcinoid tumors. We will also cover the classic clinical presentations, Pancoast tumor, and metastatic patterns. Part 2 will cover paraneoplastic syndromes, diagnosis, treatment, and screening. Let's get started. Lung cancer is the leading cause of cancer death worldwide and the second most common cancer overall. The major risk factors are: first, tobacco smoking, which causes 80 to 90% of all lung cancers. Second, radon exposure, which is the second leading cause and comes from soil and basements. Third, asbestos, which is synergistic with smoking. Fourth, occupational carcinogens including arsenic, chromium, nickel, and beryllium. And finally, passive smoking and a family history. Step 2 Pearl. Smoking combined with asbestos exposure increases lung cancer risk multiplicatively, not additively. A smoker with asbestos exposure has about a 50-fold increased risk compared to a non-smoker with no exposure. Lung cancers are divided into two major categories based on histology and treatment approach. Non-small cell lung cancer, or NSCLC, accounts for about 85% of cases. It includes adenocarcinoma, which is peripheral, squamous cell carcinoma, which is central, and large cell carcinoma, which is peripheral. NSCLC is typically treated with surgery and chemotherapy and has a better prognosis. Small cell lung cancer, or SCLC, accounts for about 15% of cases. It is centrally located, extremely aggressive with early metastases, has the strongest link to smoking of any lung cancer, and is treated primarily with chemotherapy and radiation. Surgery is rarely indicated. SCLC is also associated with many paraneoplastic syndromes. Step 2 Pearl. The central tumors are squamous and small cell. Both start with S, and both are strongly linked to smoking. Adenocarcinoma is the most common lung cancer overall. Location is peripheral. Demographically, it is the most common lung cancer in women and in non-smokers, which is an important Step 2 trap. Common mutations to know include EGFR, ALK, and KRAS. Histology shows a glandular tumor with mucin-producing cells that stain positive for mucin. Adenocarcinoma is the most common type of lung cancer to arise from pulmonary scars. Among the non-small cell types, it has the best prognosis. Step 2 Pearl. A non-smoker with a peripheral lung mass should make you think adenocarcinoma. Check for an EGFR mutation because it can be targeted with osimertinib. Squamous cell carcinoma is the centrally located non-small cell type with a strong smoking association. Imaging classically shows cavitary lesions arising from a hilar bronchus. The defining paraneoplastic feature is secretion of parathyroid hormone-related peptide, or PTHrP, which causes hypercalcemia of malignancy. Histology shows keratin pearls and intercellular bridges, which are desmosomes. To remember all of this, imagine a squawking parrot doing karate in the center of a cave under a bridge while smoking. That gives you squamous, PTHrP, keratin pearls, central location, cavitation, intercellular bridges, and smoking, all in one mnemonic. Large cell carcinoma is a peripheral non-small cell lung cancer with a strong smoking association. Histology shows undifferentiated, large polygonal tumor cells with abundant cytoplasm and prominent nucleoli. Clinically, it has a poor response to chemotherapy, develops early metastases, and overall has a poor prognosis. Some large cell carcinomas can produce human chorionic gonadotropin, or HCG, leading to gynecomastia. Step 2 Pearl. A male smoker presenting with a peripheral lung mass and gynecomastia should raise suspicion for large cell carcinoma producing HCG. Small cell lung cancer is centrally located and has an extremely strong link to smoking. It is essentially never seen in non-smokers. The course is very aggressive with early metastases, often at the time of presentation. The associated mutation is the L-MYC oncogene. SCLC arises from neuroendocrine Kolchitsky cells, which is why it expresses neuroendocrine tumor markers. chromogranin A, synaptophysin, and neuron-specific enolase, or NSE. SCLC is also famous for its paraneoplastic syndromes, which we will cover in detail in Part 2. These include SIADH, Cushing syndrome from ectopic ACTH, and Lambert-Eaton syndrome. Mnemonic to remember the histology: small blue Koha flatbread in a synapse. That gives you Kolchitsky cells, chromogranin A, NSE, and synaptophysin. Lung neuroendocrine tumor, also called carcinoid, accounts for only 1 to 2% of all lung cancers, but it is the most common primary lung cancer in children and adolescents. This is a high-yield step 2 point. Location can be central or peripheral. Unlike most lung cancers, it is not strongly associated with smoking. The clinical course is indolent with a good prognosis, and metastases are rare. Carcinoid syndrome with flushing and diarrhea is rare in pulmonary carcinoid because the venous drainage goes directly to the systemic circulation through the lungs, bypassing the liver only when liver metastases are present. The most common presenting symptom is wheezing from local mass effect on the airway. Step 2 Pearl. A young non-smoker with persistent localized wheezing or recurrent pneumonia in the same lobe should make you think carcinoid tumor. Clinical features of lung cancer fall into 2 categories. Pulmonary symptoms include cough, hemoptysis, progressive dyspnea, and wheezing. Recurrent pneumonia in the same lobe is a red flag. Local compression symptoms result from tumor invasion of nearby structures. Superior vena cava syndrome causes facial swelling, head and neck congestion, and dilated chest veins. Hoarseness results from compression of the recurrent laryngeal nerve. Phrenic nerve involvement causes hemidiaphragm paralysis, visible as an elevated hemidiaphragm on chest X-ray. Malignant pleural effusion produces dullness to percussion and decreased breath sounds. Constitutional symptoms include weight loss, fatigue, and fever. Step 2 Pearl. Recurrent pneumonia in the same lobe in a patient over 40 years old should always trigger a workup for an obstructing lung cancer. A Pancoast tumor is an apical lung carcinoma located in the superior sulcus. Because of its location, it causes a classic constellation of compression symptoms called Pancoast syndrome. Compression of the cervical sympathetic chain, specifically the stellate ganglion, produces Horner syndrome. The triad of ipsilateral meiosis, ptosis, and anhidrosis. Compression of the brachial plexus causes shoulder and axillary pain, with motor and sensory deficits in the arm and hand, including hand muscle weakness and atrophy. Compression of the recurrent laryngeal nerve causes hoarseness. Compression of the brachiocephalic vein causes unilateral arm and facial edema. Compression of the phrenic nerve causes hemidiaphragm paralysis. Step 2 Pearl. A smoker presenting with shoulder pain plus Horner syndrome is Pancoast tumor until proven otherwise. Get an apical chest X-ray or CT immediately. More than half of all lung cancer patients have metastatic disease at the time of diagnosis. The most common sites are easy to remember with the mnemonic blab: brain, liver, adrenals, and bones. Brain metastases present with headache, seizures, or focal neurologic deficits. MRI brain with gadolinium is the preferred imaging study. Liver metastases cause nausea, jaundice, ascites, and elevated liver function tests. Adrenal metastases are typically asymptomatic and are usually discovered on staging CT or PET scan. Bone metastases cause bone pain, elevated alkaline phosphatase, and elevated calcium. They can present with pathologic fractures. Step 2 Pearl. Any new neurologic symptom in a lung cancer patient demands a brain MRI. Lung cancer loves to blab. Let's wrap up Part 1. Classification. Non-small cell lung cancer is 85% of cases and includes adenocarcinoma, squamous cell, and large cell. Small cell lung cancer is 15% and very aggressive. Adenocarcinoma is peripheral, most common in women and non-smokers, with EGFR, ALK, and KRAS mutations. Best prognosis among non-small cell types. Squamous cell carcinoma is central, cavitary, linked to smoking, and produces PTHrP causing hypercalcemia. Histology: keratin pearls and intercellular bridges. Large cell carcinoma is peripheral, undifferentiated, with poor prognosis. can produce HCG, causing gynecomastia. Small cell lung cancer is central, strongly linked to smoking, very aggressive, with Kolchitsky cells expressing chromogranin A, synaptophysin, and NSC. Many paraneoplastic syndromes. Carcinoid is rare overall, but the most common primary lung cancer in children. Wheezing from mass effect. Good prognosis. Clinical features: cough, hemoptysis, recurrent pneumonia in the same lobe, SVC syndrome, hoarseness. Pancoast tumor causes Horner syndrome, shoulder pain, and arm weakness. Metastases follow the blab pattern: brain, liver, adrenals, and bones. Over half have metastases at diagnosis. Finally, the classic step 2 traps. A non-smoker with a peripheral mass is adenocarcinoma. A male smoker with gynecomastia is large cell carcinoma. Smoker with shoulder pain plus Horner syndrome is Pancoast tumor. And recurrent pneumonia in the same lobe in an older patient demands a cancer workup. In part 2, we will cover paraneoplastic syndromes in detail, diagnosis with imaging and biopsy, treatment by stage, and lung cancer screening. See you there.